Ladies and gentlemen, thank you for standing by and welcome to the Lewin Group Successfully Engaging Members in Plan Governance conference call. This time all participants are in listen-only mode. Should you require assistance on today's call, please press star, then 0. I'd now like to turn the conference to our host, Ms. Alana Moore. Please go ahead.
Thank you. My name is Alana Moore. I'm with the Lewin Group. Welcome to the webinar, Successfully Engaging Members in Plan Governance. This is the first session of our 2019 Member Engagement and Plan Governance webinar series. Today's session will include a 60-minute presenter-led discussion, followed up with 30 minutes for a discussion among the presenters and participants. This session will be recorded. A video replay and a copy of today's slides will be available at www.resourcesforintegratedcare.com. The audio portion of the presentation will automatically stream through your computer. Phone lines for this presentation are also available. To access the number, click the black phone widget at the bottom of your screen. Continuing education credits are available at no additional cost to participants. CMS is accredited by IECET to issue CEUs, and the National Association of Social Workers, NASW, is accredited to provide continuing education for social workers. We strongly encourage you to check with your specific regulatory boards or other agencies to confirm that courses taken from these accrediting bodies will be accepted by that entity. You'll see on this slide that we've laid out the various continuing education credit options. If you are a social worker, you can obtain continuing education credit through NASW if you complete the pretest at the beginning of the webinar and complete the post-test. CMS is also offering CEUs for other individuals looking to obtain credit for attending this webinar. In order to obtain these credits, you must complete the post-test through CMS's learning management system. Additional guidance about obtaining credits and accessing the links to the pre- and post-tests can be found within the Continuing Education Credit Guide in the resource list on the left-hand side of your screen or at the Resources for Integrated Care website. This webinar is supported through the Medicare-Medicaid Coordination Office at the Centers for Medicare and Medicaid Services. MMCO is helping beneficiaries duly eligible for Medicare and Medicaid have access to seamless, high-quality health care that includes the full range of covered services in both programs. To learn more about current efforts and resources, please visit our website or follow us on Twitter for more details. Our Twitter handle is @integrate_care. At this time, I'd like to introduce our moderator. Renee Marcus-Hoden is the Deputy Director of Community Catalyst Center for Consumer Engagement and Health Innovation. For the past 20 years, Renee has worked to bring the consumer perspective to the forefront of health and health innovation. Renee?
Thanks so much, Alana, and welcome, everyone. I wanted to wish a good morning or a good afternoon, depending on where you are, to everyone participating in today, and particularly those who are joining us from the Midwest. I hope you're staying safe and warm. I'm so pleased to be with all of you today and to moderate the webinar. As Alana mentioned, I'm the Deputy Director of the Center for Consumer Engagement and Health Innovation at Community Catalyst. And as you might gather from our name, the topic of this webinar is truly central to our mission of ensuring that the people served by our health system are engaged in all efforts to improve that system. Next slide, please. I'm pleased to introduce our speakers today and also to offer a roadmap for our time together. We'll start by hearing from my own colleagues at the Center, Lena Sharma and Mark Cohen. Lena is a Senior Policy Analyst who also heads up the Center's work on Medicare-Medicaid enrollees. Lena has been doing this work here at Community Catalyst in the Center since 2011, and before joining us here, she served as the Public Policy, Advocacy, and Volunteer Coordinator at the Greater New Jersey chapter of the Alzheimer's Association. Mark is the Center's Research Director and also serves as the Co-Director of the Leading Age LTSS Center at UMass Boston. Over his 25-year career, he's conducted extensive research and analysis on a variety of public policy issues affecting the financing and delivery of long-term care services. Together, Lena and Mark will share the findings of their recently completed research on the Consumer Advisory Councils established by Medicare-Medicaid Plans, or as we may refer to them as MMPs, who are participating in the Financial Alignment Initiative. These bodies are just one way that plans can engage their members in governance. Next slide, please. We'll then hear from two different MMPs, both of whom I might note are from the frigid Midwest, so they get extra credit for showing up today into their offices to present to us. We're going to hear from them about how they engage their own members in the governance of their plans serving Medicare-Medicaid enrollees. We'll first hear from the team from Aetna Better Health of Michigan, Angela Addo and Katherine Example. Angela is the Community Development Manager at Aetna Better Health. In this role, she heads up the community outreach team to increase brand awareness and grow plan membership among Medicare-Medicaid enrollees. Katherine is part of this team, serving as the plan's Community Development Coordinator. As part of her role, she plans and facilitates the plan's Member Advisory Council meetings. Angela and Katherine will share with us information about the structure of their council, how they've recruited and supported members to serve on it, and very importantly, the kinds of impact it's had on plan operations. Next slide, please. We'll then shift to Ohio and hear from the team at CareSource, Chris Rossi and Robin Rohr. Chris is the Director of Consumer Experience at the plan. In this role, Chris leads efforts to help the plan see itself through the eyes of its members. She's responsible for connecting plan leaders with member insights that inform their decision-making and development opportunities. Robin is the Senior Insight Manager responsible for developing a common understanding and focus on consumer experience by ongoing research, collaboration, and maintaining a shared consumer understanding. In this role, Robin designed, developed, and maintains the plan's member advisory committees. Like the team from Aetna, Chris and Robin will share with us information about the structure of CareSource's councils, how they've recruited and supported members to serve on them, and examples of the influence and value they've had on plan operations. Next slide, please. Here are our learning objectives for the session today. By the end of today's webinar, participants should be able to demonstrate knowledge of the member engagement approaches used by MMPs serving dual-eligible beneficiaries. They should be able to recognize strategies that health plans use for recruiting a diverse group of members for roles in plan governance. They should identify issues on which members who are engaged in health plan governance can have the greatest impact. And they should also be able to recognize strategies for building a culture of engagement within health plans and other systems that are serving populations with complex health and social needs. Next slide, please. And so today we're going to go through this agenda as a sense of how it's going to go. We're going to start with a couple of polls to get a sense of who's in the audience. We'll then shift into a brief overview that I'll offer to make sure we're all on the same page about what we mean by governance and why it's important to engage members in plan governance. We'll then hear from our speakers, but we'll also leave plenty of time for questions and answers. And then finally, we ask that you all stay on afterward just to complete a brief evaluation of the webinar. It truly helps us understand what you gained from it and what we could improve on and offer the next time. So next slide. Let's start with our first poll to understand who's with us today. So first poll is, in what setting do you work? Health plan, ambulatory care setting, long-term care facility, home care agency, community-based organization, consumer organization, if you're in academia, or there might be other. Please just select one. And we'll give everyone a chance to choose one. Okay, I think we're almost getting all of the results. Maybe we can start showing the poll results. Okay, so far, though I suspect we may not have absolutely everybody who responded yet showing here, but by far our primary audience here is health plans, which makes a lot of sense. Let's go to the next poll. So we're going to dig just a little bit deeper to find out who you all are, and if you could select the button that best describes your professional area, whether you're a health plan case manager or a care coordinator, whether you're in customer service at a health plan, administration or management, whether you're in another type of healthcare administration, some sort of provider, in pharmacy, social work, advocacy, policy or research, or something entirely different. Again, you can only select one, so just select the one that best describes your professional area. Okay, why don't we take a look at who we have in our audience. Let's take a look at the results. Okay, so it looks like we are largely, again, reflecting our last poll. We have lots of folks from health plans. We have a good segment, about a quarter of our audience from who are case managers or care coordinators, as well as about a third that are in administration and management in health plans. Great, thank you so much. It's great to know we have a lot of concentration in health plan participants. So let's go to the next slide. As I mentioned, I wanted to, oh, I'm sorry, this poll came next. So let's also get a sense of how you all currently engage your members, or if you're a provider not in a plan, your patients, as the case may be. Do you use advisory councils or committees? Do you have members that are part of boards of directors or board committees, involved in quality improvement initiatives, focus groups, surveys, or something altogether different? In this case, you can choose all that apply. Okay. Why don't we go to the results? Okay, about half of participants note that they use committees and councils. A good number of people involve members or patients in quality improvement initiatives, and lots, almost half, also use surveys, and a good number use focus groups. That's terrific. It sounds like there's a good smattering of approaches. Okay, now we'll go to the next slide, to the overview about what we really mean by governance, just to make sure we're all on the same page, as I said earlier, and also why it's important to engage members in these approaches. So first, what do we mean when we say engagement in plan governance? We're really talking about engagement at the organizational level for the purpose of improving the design and the operations of the plan or practice. This is quite different from the kind of member engagement we hear an awful lot about these days, which is engagement of the member in their own care. That's not our topic today, but I will note that there are many resources on this topic on the Resources for Integrated Care website from previous webinars and other publications. So again, what we're referring to today are those types of approaches that include soliciting member feedback through the mechanisms we just polled you on. So advisory committees, which will be most of our focus today. But as I said, it can also refer to members serving on boards of directors or board committees, quality improvement work groups, as well as participation in other approaches to gathering member feedback through town hall meetings, member meetings, focus groups, or surveys. So why solicit member feedback in the first place? What is the value proposition? And for this, I wanted to point you to the National Academy of Medicine, who in 2017 developed a guiding framework for what they called patient and family engaged care. I always find this helpful in understanding why these types of approaches are helpful to improving care overall. So basically, these types of structures that we just talked about are the kinds of strategic efforts necessary to produce several types of positive results, and this is in that National Academy of Medicine framework. So those results include better engagement, which can be seen, for example, through increased member or family activation, better decisions, which might be reflected, for instance, in increased health confidence in making decisions about care, better processes, such as improved care coordination, and better experience for the plan, providers, and most importantly, the member, which can be indicated by improved communication or in a decrease in grievances. So I encourage you to take a look at that framework at the NAM website, and I also should note that it includes a wonderful bibliography of the emerging evidence base for member engagement. Finally, when we ask why engaging members in governance is important, we believe that decisions related to member care should always involve members. This reflects strongly the principle of co-design, which I'm sure many of you are familiar with, as well as the oft-heard mantra of communities like the disability community who say, "Nothing about us without us." So with that as an overview, I'll turn things over to my colleagues at the center, Lena Sharma and Mark Cohen. Lena, Mark?
Great. Thank you, Renee, and good afternoon, everyone. So in our brief presentation today, my colleague Mark Cohen and I will be sharing with you some of the findings from our recently published paper on consumer advisory councils in the capitated model of the Financial Alignment Initiative. So as most folks know, consumer advisory councils are a requirement written into the three-way contracts between CMS, the state, and health plans, Medicare-Medicaid plans. These requirements range from very simple to detailed requirements. So, for example, as you'll see on the slide here, in Michigan has very detailed requirements mandating that advisory councils be composed of at least one-third enrollees. Participants should reflect the diversity of the enrollee population. At least one-half enrollees, caregivers, and local representation from key community stakeholders such as advocacy organizations, faith-based organizations, and other community-based organizations. Next slide, please. So we were really interested in understanding the composition, function, and impact of consumer advisory councils now that the demonstrations had been operating for a few years. So in order to really understand those different aspects of consumer advisory councils, we collected and analyzed data through a mixed method approach. We first conducted an online survey, which we distributed to 35 Medicare-Medicaid plans with 5,000 or more consumers enrolled, 21 of whom responded to the survey. And you'll note here on the slide that eight plans from these states responded to the survey. We also conducted telephone interviews with consumers, consumer advocates, health plan representatives, and officials from the CMS Medicare-Medicaid Coordination Office. Next slide, please. So one of our first findings was around consumer advisory council recruitment and training. And based on our survey responses, showed that many of the plans don't have typical formal processes to recruit enrollees to participate on the advisory councils, but they have various outreach strategies to recruit members. So, for example, they'll use their care management or member service departments to identify potential participants. They'll invite enrollees with whom they or other members of the advisory council have prior relationships, or they'll conduct outreach to enrollees at community events or through community-based groups, or perform direct outreach to enrollees through either cold calls or flyers. Also asked a question about trainings, and the response was 65% of the plans reported that they do train consumers on how to work effectively on advisory councils. These trainings range from formal orientations that feature mock advisory council meetings to casual overview of the purpose of advisory councils and the consumer's role. Next slide, please. So you'll see on this slide one of the questions that we asked and what we found was around how participants are supported and what incentives are provided to consumers. And you'll note that transportation, food, ability to accommodate by a care attendant were the most popular forms of supports and incentives provided to participants. The other ones are meetings are held in ADA compliant locations. There are translation services provided. Some provide gift cards and stipends, and 5% provide child care. Next slide, please. Our next finding was on common topics on Consumer Advisory Council and how agendas are set. This was a select all that apply question on the survey, so they do not have to be included on every agenda. And many of the plans vary on how they determine which items get included on the Consumer Advisory Council meeting agendas and in the type of items that they commonly discuss. Nearly all of the plans reported that their staff and consumers work together on setting the agenda. And as you can see on this chart, the most common topics with member benefits and care coordination as being the most popular. Member benefits at 57% and care coordination at 52%. Next slide, please. On this slide, you'll note some of the responses we received on racial and ethnic representation on consumer advisory councils compared to plan membership. As you've noted on the earlier slide, in Michigan, having a diversity of the enrollee population has been written into the requirements of a lot of the consumer advisory council and the three-way contracts. and having diverse consumer representation is necessary to ensure that the needs and voices of different communities served by the MMP are considered. Our survey asked respondents to report on the race, ethnicity of consumers participating on the Advisory Council and within MMP membership. So the dark blue is the percentage of MMPs with consumers of race and ethnicity enrolled, and the lighter blue shade is a percentage of consumer advisory councils with consumers of race, ethnicity that are participating. 21 survey respondents were aware of the race and ethnicity of the consumers within their membership and of those who participate on the Advisory Council. An important point that I want to make is we obtain this information on whether or not certain race ethnicities are represented, but not on the proportion of races or ethnicities participating on the Advisory Council or within the member body. The information collected here suggests that there are disparities between the reported race ethnicity profiles of MMP membership and that of associated with consumer representation on the Advisory Council. So, for example, the Asian Native American population are the most underrepresented of the 12 MMPs that enroll Native American, Alaskan Natives, and Pacific Islanders. Only 3 have consumers from this community who participate on their consumer advisory councils. Next slide, please. And at this point, I will turn it over to my colleague, Mark Cohen.
Thank you very much, Lena, and thanks to everyone for joining us today. One of the important learnings from our research is that consumer advisory councils don't just automatically set themselves up, but they really require investment to work well and be effective. Creating and maintaining them it's a serious undertaking that requires staff, time, and resources, and a dedication to listening to consumers. It also requires a level of activity at meetings that ensures that the consumer voice is drawn out and heard. Results from the survey suggest that the most common challenges faced by plans are that enrollees wanted to discuss personal issues rather than agenda items, and that plans themselves face difficulty recruiting consumers to participate in the councils. Even for those who come to regular meetings, almost 2 in 5 plans reported that members do not actively participate. And there are some difficulties associated with retaining members. Now, some of the plans presenting a little bit later on will share how they address these particular issues. During our qualitative interviews, one of the members of an advisory council said that what is most important is making the experience on the advisory council member-focused, which makes it easier for them to know what their role is. The meeting has to be, quote, kept in a place where consumers are able to give input and advice on issues that seem most relevant to them. Next slide, please. Overwhelmingly, the information from the advisory councils is shared with the plan management. And in fact, more than half of plans indicate that their management participates in these meetings. The other half of plans has staff report back to them. Clearly, the presence of staff at the meetings signals that they're valued by the MMP. Now, most plans do not have the staff that participates in the advisory council report directly into the plan's quality improvement area. And this is something that plans may want to think about in terms of assuring that there is good coordination from about the information that flows from the advisory committee back to the plan so that they can obtain results. Bidirectional flows of information between advisory councils and plans are necessary to ensure that the councils can create really meaningful change. These channels allow consumers to communicate feedback to health plan leadership, and health plan leadership can then make decisions based on this feedback and communicate progress back to advisory council participants. Could I have the next slide, please? Almost all plans share information from plan leadership back to the advisory council. And when this is done, information is typically provided by other health plan representatives who attend meetings in person or sometimes remotely. Of course, when plan leadership attends, they themselves provide information, and most of it is done verbally and not necessarily in writing. We expected that plans that utilized multiple methods to communicate with the advisory council would also support multiple modes of communication in the other direction. that is, from the advisory council back to plan leadership. In fact, we did find a strong correlation between the number of methods used to communicate to plan leadership and the number of methods used to communicate from leadership back to the advisory council. The implication is that there appears to be a reciprocal commitment to making sure that the information generated at the meetings and their impacts on policy and/or practice are communicated in multiple ways. Could I have the next slide, please? A key question that underlies all of this research is whether and how the consumer advisory councils influence policy and/or practice that makes a real difference for consumers. As shown in this slide, survey respondents report that advisory council deliberations have indeed changed how plans perform member outreach and how they structure or deliver benefits. Moreover, results of discussions have also altered how non-medical challenges, that is, certain social determinants of health for members, are also addressed. Clearly, most plans believe that the deliberations at these meetings have led to both practical and very granular changes in practice. For example, changing non-emergency transportation vendors, as well as to changes to plan policy as it relates to enrollment, including the way that plans communicate and do outreach to members. To be more concrete, an advisory council member recounted how members' 90-day supply of prescription medication by mail had been changed in a way that led to medications being dispensed in 30-day quantities. Members were not aware of this. The staff participating in the advisory council brought this concern to the quality improvement team, who confirmed what consumers are reporting and the challenges that this presented to them. And the plan quickly reinstated the 90-day supply of medications. This again makes the point that was made earlier, which is that these councils provide a very valuable institutionalized platform or mechanism for consumers to let plan leadership know what is really important to them. Could I have the next slide, please? I'm going to raise just a few concluding thoughts that supplement what is on the screen in front of you. First, the vast majority of plans operate advisory councils for the value they provide for both the plan and their membership. We discerned a sincere desire among many plans to elevate the consumer voice into their operations, which was at the core of why and how they operated their advisory councils. Second, it requires ongoing engagement with advisory council members to develop meaningful meeting agendas, to overcome physical, financial, and language barriers, and to be very intentional about creating efficient and reliable feedback loops. Third, the issues addressed in the advisory council meetings did have an impact on a host of issues, which demonstrates the real potential these councils have to better help plans meet the needs of their membership. And finally, these bodies require investment in training and educating members on the purpose of advisory councils, how to communicate ideas and thoughts effectively, how to develop and stick with an agenda, and the need to focus on systemic and not necessarily personal issues. This also means investing in assuring diverse representation on the council by targeting specific communities for recruitment, and in particular, those who have historically experienced disparities in accessing health care. At this point, I'm going to turn it over to Angela and Katherine to continue with our presentation.
Thank you very much. So my name is Angela Adele, and I'm the Manager of Community Development for Aetna Better Health Premier Plan here in Michigan.
Good afternoon. My name is Katherine Example, and I am the Community Development Coordinator for the Aetna Better Health Premier Plan here in Michigan.
And today we're going to be talking about the fundamentals of engaging members in plan governance. Next slide, please. So I'll start with a brief overview of Aetna Better Health Premier Plan in Michigan. We are an MMP, or Medicare-Medicaid plan, serving individuals 21 and over who are fully eligible for both Medicare and Medicaid. We are the second largest MMP in Michigan with about 6,500 members, And we were launched in 2015 as part of the Medicare-Medicaid Financial Alignment Demonstration, which is called My Health Link here in Michigan. The demonstration here in Michigan has 4 service regions, but we operate in 3 of them. 2 are on the southeast side of the state, and 1 is on the southwest side of the state, and we'll talk about that a little bit more in the presentation. I just wanted to draw your attention to our Aetna value wheel here on the right side of your screen. It talks about our 4 core values: integrity, excellence, inspiration, and caring. And it just says that everything that we do here at Aetna centers around the people that we serve. Next slide, please. So I want to give you a brief overview of our Premier Plan membership. So this is the total membership for the plan. And this shows our membership by race. About 49% of our membership is non-Hispanic white and 41% is non-Hispanic black. About 2% of our membership is Hispanic, and about 2% classify themselves as other, which could be Arabic, Native American, or Asian. And we do not know the ethnicity of about 6% of our population, as it was not provided during the time of enrollment. Next slide, please. So this slide shows our membership by sex and age. One thing that I did want to point out is that 55% of our members are under the age of 65. So when you think about individuals who are eligible for Medicare in any way, you tend to think of individuals who are 65 and up, but we do service individuals who are 21 and up. So we have a large portion of our population who is from the ages of 21 to 64. So we always just try to keep that in mind when we think about the way that we do outreach and the way that we recruit members to our advisory council. And I just wanted to add that 57% of our membership is female. Next slide, please. So our advisory council here in Michigan is composed of members, stakeholders, and guardians of enrollees. And the purpose of the council is to gather feedback about plan programs, services, materials, and cultural competence. Our advisory council also reviews and recommends strategies for creation and improvement of all programs, services, and materials. Next slide, please. So I wanted to give you guys a brief overview of how we recruit members to our advisory council. So we use 2 methods primarily, which are community outreach events, which include senior health fairs, food distributions, and events at senior housing facilities. So a lot of times we'll have a member come up to us and say they're a member of Aetna Better Health Premier Plan. Sometimes they'll even show us their card, and they'll give us some feedback about the plan. We try to keep our advisory council applications on hand at community outreach events so that we can hand it to someone if they express interest in the advisory council once we talk to them about it. And they can fill it out then, or they can mail it, they can take it and mail it. Our application is also available on our website online, so members can download it and send it in if they're interested in participating. We also use our care coordination team to make recommendations about advisory council members. So our care coordinators will often recommend members who are very actively engaged in their care plans or who provide really good feedback about plan services and how they are working. And so they feel like if a person is able to really be active in their own care planning or provide really good feedback, they would be a good candidate to participate on our advisory council. So then we'll have the person fill out an application. Next slide, please. So as I mentioned earlier, Aetna Better Health Premier Plan operates in 3 of the 4 service areas in the state of Michigan for the MMP demonstration plan. We operate in Region 4, which is in southwest Michigan and contains 8 counties. And this region tends to be more rural. We operate in Region 7, which is Wayne County, where the city of Detroit is located. We also operate in Region 9, which is Macomb County. And Region 7 and 9 are more urban areas. So you can see a brief overview of the demographics of our members. In Region 4, we have 16 members and 3 caregivers on our advisory council. Our advisory council is 58% female and 63% Caucasian. We also have a Native American representation on the advisory council, and the age ranges from 33 to 74. In Regions 7 and 9, we have 7 members. 57% of our members are female. 100% of our participants are African American, and their age ranges are 39 to 74. We did want to point out that if you look at our 2 advisory councils on each side of the state in total, it's a closer representation of our plan membership as far as demographics are concerned. So 50% of our total advisory council is African American, 46% is Caucasian, and of course 4% is Native American. One thing that we are looking at next year is we want to assess where we have any diversity gaps on each side of the state and tweak our recruitment efforts to ensure that the council is a representative of the plan in each region. Our council meets 4 times a year on each side of the state, so we have 8 meetings in total. We provide transportation along with a $25 stipend and lunch to support participation. And I really want to emphasize that our council is fully engaged with the plan. We do not have issues with attendance. Our council members are super excited to attend the meetings, and when they do miss a meeting for whatever reason, they are really upset about it. So we have really had great participation from our council. Next slide, please. So with that, I will pass it to Katherine so that she can talk to you about building a culture of engagement.
Thank you, Angela. So we want to discuss about how we build a culture of engagement in our advisory councils. Well, first off, we do encourage an open environment free of judgment. Our MAC charter actually indicates that each member can be confidential in anything that's shared within the advisory council meetings and listen to each other with respect of each other's views and opinions. In addition to that, every meeting we do have a little verbiage at the bottom of our sign-in sheet that just reiterates the policies for the MAC charter, that we do respect each other's opinions and that we keep everything confidential. And this includes any guests that come to the meeting that are not regular attended advisory council members. They do also sign a non-disclosure agreement. In our advisory council, all of the topics are centered around the members, not the health plan. So our members have the floor for the majority of the meeting, and our members, caregivers, and partner agencies sit at the boardroom table, and staff tend to sit along the wall. Depending on the size of our meetings that day, we could have additional guest speakers that make our meeting larger, so our staff tends to sit away from the table so that the focus is still on the members and the caregivers. Our advisory council members can suggest meeting topics. For instance, we did have a member suggest transportation, and our transportation vendor has been coming to the meetings for the past few years, and our members provide feedback on their policies and what they could do to help improve transportation process. For instance, they did suggest perhaps having ID cards for their drivers so that they can verify that they are working with the transportation company, as well as improvements to the transportation vendor customer service team. Our members are also able to invite guest speakers, so if they have topics or people they'd like to hear information about that could help our health plan, they are encouraged to invite people to attend, and we can get that put on the agendas. So our members do lead the conversations. When we have our vendor with transportation there, our members are fully engaged, and they are the ones doing all of the legwork. We're just there to help facilitate the flow of conversation. Members can also provide feedback on proposed agenda items. We typically will send out the invitation to the meetings about 1 month prior to the meeting that's scheduled. And inside that invitation, we do include a proposed agenda. If a member decides there's something they want to talk about, they can call us with a proposed agenda item, or at the end of all of our meetings, we do ask them to provide any new topics that they want to discuss for the next council meeting. We did have one of our members ask for information about the opioid crisis and how it affects access to pain medications. So one of our meetings, we did invite our director of pharmacy to discuss the limitations of prescribing opioids and the hoops that we have to jump through to get those medications administered. Because of that, and our members have interest in the Narcan training, learning about the opioid crisis, so we're looking at implementing those kind of trainings as well as CPR classes that they've expressed interest in as well. Next slide, please. So if you look at the graphic on your right, you'll see how our advisory council, the health plan, and the quality management improvement oversight committee all work together. So the flow of communication is open, and it all reports up to our plan's governing board. To keep that fluid, one of our advisory council members also serves on our plan's governing board to act as a liaison between the two entities. Our CEO also attends all of our advisory council meetings as well as all of the plan's governing board meetings. And in her absence, if she's unable to attend, she does send the COO for consistency of executive leadership in both of those meetings. All of our advisory council meetings are reported to the Quality Oversight Committee as well as the plan's governing board. And here you'll find that the importance of having the advisory council members serve on the governing board so that they can ensure that the information that we did report on the minutes is properly reported to the governing board. Members can provide feedback from any of the council meetings to the health plan that need to be implemented, and it gets reported to the respective department of the health plan. If any changes or updates need to be made, they are shared with the committee and reported back to the advisory council. Next slide, please. So the impact that the advisory council has on the health plan here at Aetna Better Health Premier Plan, most recently it's member communication materials and marketing pieces. Our members wanted to have more information about communication with what's happening with benefits, typical health information, so that's led to a creation of a member magazine that we're actually working on. Now this magazine would contain any updates about benefits for the health plan that will also be included in their new member handbook at the beginning of the year. However, it's in a more attractive format as far as a glossy magazine type style publication. So we would have updates about benefits as well as different health, like around the flu season, we might put an article about getting your flu shot and any kind of vaccinations that are pertinent to our membership body. This past year, we did a complete overhaul of our member outreach brochures and materials. Our members provided feedback on the appearance and content of the brochures. They wanted us to include more inclusive photos that reflect the proper age, sex, and race of our membership population. So we did add some more diverse photographs in our marketing materials and made the materials easier for communication to our audience. Council members do bring us information about competitor benefits and ask us to compare our offerings to make our health plan more competitive. So based on this information, we do review that, and sometimes we can add or change our benefits. As any new or revised benefits are implemented and the marketing materials for the benefits are designed, the council is consulted to ensure that 1, the benefit is administered in any way that makes it easily accessible to members, and 2, that the marketing materials clearly communicate what the new benefit is. So this past year, we did a revision of our value added benefit package for members. The past few years, we've had an over-the-counter benefit of $20 a month from a specific catalog. Based on recommendations from our council, we changed that this year to a $90 quarterly stipend, or excuse me, a quarterly amount that they could use by either a debit card to take to participating retailers, or on our website, we do have an online link that they can order those items as well. And if they have any issues accessing the internet, their care coordinator can help them with that too. And also additionally to 2019, our members highly advocated for a fitness benefit to be more competitive with the other health plans. So we did add that to the benefit. And with the revision of these new benefits came into the next slide that we'll get into, and I'll show you the breakdown of what happened. Next slide, please. So on your screen, you're going to see an example of one of our newest brochures that we came up with this year. On the left side of the screen, we did include a more diverse photograph that represents our member body, as well as right next to it, there's a list of all of the covered benefits that are required of all MMP plans. On the other side of that flyer is a breakdown of all of the additional benefits that Aetna Better Health Premier Plan offers our members. So we highlight the difference of what's basic covered and then what we cover in addition. So this also highlights the increased over-the-counter benefit as well as the new fitness benefit that we offer. Next slide, please. And I'm going to hand it over to Angela. She's going to talk about our CAP scores.
Thank you, Katherine. So one of the things that our advisory council has been really helpful with is kind of getting a little bit more insight into our CAHPS scores. And as many of you know, the CAHPS is the Consumer Assessment of Healthcare Providers and Systems Survey. And we just wanted to get a little bit more insight into some of the scores that we would like to improve. So the first thing that we wanted to ask our advisory council members about was how we could improve our response rate for the survey. And we explained to them that it's a survey that health plans send out to assess member satisfaction with the plans and providers. And we just wanted to kind of get their feedback about that. And we also explained to them that the survey is used to compare us against other plans that are similar to ours. So one of the things that they asked us was, hey, who actually receives this survey? So we explained that we don't know who receives it, but it's only a subset of the membership. So the advisory council suggested that we send out a communication to all of our members prior to the implementation of the CAHPS survey to let them know that the survey is coming out and that we would appreciate their honest feedback. And they also said that we should let members know that if there is any outstanding concerns or any things that they think where they would rate us, they wouldn't rate us well, that they should contact member services and try to see if they can get those issues addressed. One of the other items that we wanted to ask advisory council members about as far as our CAHPS scores were concerned was the availability of specialists in our provider network, because our scores were not where we would like them to be. So the advisory council gave us feedback that perhaps one of the reasons that why people didn't rate us as we would have liked to have been rated was because there's some confusion about prior authorizations and what services require prior authorizations and the difference between prior authorizations and referrals. So as part of the member magazine that Katherine mentioned earlier, we are putting an article together to explain the difference between referrals and prior authorizations and to list some services that might need prior authorizations. We also learned during this discussion that especially on the west side of the state where we have a more rural area, that specialists are not as easily accessible as members would like them to be. So we are sharing that information with our provider services team to ensure that certain specialists are more easily accessible for our members. There were also two other kind of topics that came from discussion with our advisory council about ways that we can better communicate with our members and educate our members. So our members expressed that they were having issues accessing their dental benefits. And what we found out is that our members would call the dental office and say, hey, I have Aetna, do you accept that? And the dentist would, the dental office would say, yes, we do. But in fact, Aetna Better Health Premier plans are covered by DentaQuest. So we identified that as an opportunity for member education about how members actually access their dental benefits. So we are creating a marketing piece to notify members about, all of the dental services that are covered and to let them know that if they need help finding an in-network dental provider, that they should contact member services. We recently learned that members are not aware of the grievance and appeals process and that they do have the right to file a grievance or to appeal a decision that the health plan made that they are not satisfied with. So we're in the process of creating educational materials around that particular topic as well. Next slide, please. And with that, I'll pass it to Katherine to wrap up.
Thanks, Angela. So we talked about the impact of the Advisory Council on the health plan itself, but we want to wrap up the discussion about the impact the Advisory Council has on our Advisory Council members. And with that, our Advisory Council members have a shared sense of purpose among our members. They're making a difference for the health plan, our members, and potential members that will enroll into our health plan. They meet other people and other members who share similar experiences, and members express gratefulness of knowing that they're not alone in their health journey, that some people have similar experiences, whether it be housing issues, whether it be certain ailments. But it's nice that they meet people that have these same experiences in life. They meet new friends among these. So a lot of people, a couple of our members have exchanged phone numbers and interacted with each other between our meetings. So that's something that we encourage at the health plan, socialization, and watching these relationships flourish over the past few years has been very warm to know that this that comes from the advisory council. They have a feeling of family, so our advisory council is very welcoming. Everybody knows everybody, and one of our members shared how our council was like her family, and that the health plan and the membership of the council shows better concern for her in certain instances than her actual family. So that's something that is openly expressed and that we find very beneficial to our particular council. And our advisory council is member-centered, as I reiterate, but it's also very self-sustainable. We have 100% confidence that if we were to ever leave the health plan, Angela or myself, that our members will continue leading the discussions and the council will continue. Aetna Better Health Premier Plan staff helps plan and facilitate the meetings, but the members do lead it. And one last example I kind of want to leave you with is we hosted an Aetna senior leadership meeting at our office here in Detroit. And as part of their visit, we had our member advisory council members make a presentation to our executive leaders from all of the Aetna Medicaid plans in our region, including 2 other MMP plans, so they can provide insights to successes and barriers in our programs. It was powerful, and they provided invaluable insights, and we think it further demonstrates the value that we place on the input of our advisory council. So our members feel empowered to make these decisions and to speak on behalf of all of our members here at the health plan. Aetna as a whole has a tagline, "You don't join us, we join you." And with our advisory council, it's just that. They don't join us, we join them. Thank you for listening to our part of the presentation, and we are going to pass it over to Chris Rossi and Robin Rohr.
Hi, thank you. This is Chris, and I lead the Consumer Experience Department at CareSource. Robin and I are pleased to share our approach for creating successful advisory councils today. Next slide, please. CareSource, I wanted to offer a bit of a context about CareSource. We are a nonprofit, mission-based managed care organization founded in Dayton, Ohio in 1989. We serve approximately 2 million members across 4 different product lines, and we are in 5 different states or markets as we refer to them. As a company, we focus on the most vulnerable populations, with our largest volume of membership being in Medicaid. Our MyCare demonstration, which is relevant to our topic today, is based in 3 regions in Northeast Ohio, which is the Cleveland area, and has approximately 30,000 MyCare members. Next slide, please. Our consumer advisory councils are part of a larger strategy within CareSource to collect and act on member and provider feedback. The Consumer Experience, or CX department, manages our advisory councils in most of our markets of business, and that includes MyCare. Within our department, we have staff who are responsible for ensuring success. As Mark mentioned earlier, advisory councils are a very large effort, and we want to make sure that they're meaningful for our members as well as for our business owners. What you'll see here is kind of a large-scale process flow that shows you how we use feedback that we collect. So the first part of our process is that the CX department collects qualitative and quantitative feedback across all product lines and markets. We collect this information via surveys and other methods, including the advisory councils. The second part of our overall process involves sharing that information back with our market leaders and business owners. So we share detailed summaries with those leaders, and we also regularly share overview summaries with the entire organization via our internal website. We try to be as transparent as possible with our staff about the information that we gather about our members. And finally, the goal of sharing this feedback is really to drive improvements. So accountable parties form action plans to address areas of opportunity that are identified through these various methods. Now I'm going to hand off to Robin Rohr, a Senior Insight Manager within the Consumer Experience Department. Robin has played a lead role in developing and refining our Member Advisory Council approach.
Thanks, Chris. As Chris mentioned, we conduct quarterly council meetings in each of the 3 regions we serve our dual-eligible members. The meetings are 90 minutes each, and we follow an interactive focus group style format. In addition to the MyCare member and family caregiver attendees, we also include community advocates and local ombudsmen. The meetings are well attended by CareSource employees that Chris had mentioned. These employees might be care managers, those in positions of leadership at CareSource, and others for whom the discussion topics might be hyper-relevant. So for example, if we're getting feedback on the effectiveness of a particular member communication piece, the marketing team member responsible for this document would come to hear the member feedback directly. As another example, during last quarter's meetings, we conducted user testing of our new website. A few of our digital strategy team members came to the meetings to watch the members interact with the new platform. And through this exercise, we also learned a lot about our members' online habits and the challenges that many of our non-computer literate members face. Next slide, please. Our member meetings have evolved a lot in the last 4 to 5 years to be true advisory meetings. We think of them as ongoing focus groups, which really helps to guide our approach and gain insight to drive improvement strategies. We found that the best meeting locations are free or low-cost facilities that are well-known and easily accessible. So places like community centers, YMCAs, libraries, and senior centers work very well. Meeting times that are scheduled around the lunch hour also make it convenient for the members to attend. Evening meetings are sometimes necessary, though, to accommodate members' schedules as well. So to maintain diversity, we randomly recruit members who are mapped to be within a close radius to the meeting facility. So if they live within a 15 or so minute commute, they're more likely to come to the meeting. We also make sure the location's close to a bus stop when possible. Our goal is to land on an established group of members, as Aetna does, who consistently return to the quarterly meetings. By having established members, you're able to build upon learnings over time and work very collaboratively on developing new initiatives with this group. Katherine talked a lot about the ways they do that as well. If different members come to each of the meetings, it's much more difficult to do this. When establishing a new council, it might be necessary to cast a wide net for the first few meetings. We may mail invitations to 3,000 members in order to get 10 to attend. But if they see value in the meeting, they're very likely to return to the next one. After a few rounds of this initial recruiting, you should be able to land on an established group of around 15 or so who will return to the upcoming meetings. Our goal is to have around 10 members at each meeting for an ideal focus group format. To prepare members to participate effectively, orientation and training is provided to the new groups to set expectations and provide motivation. A few expectations we set for council members is that they're active participants and that they share their feedback. We also set the expectation that CareSource will utilize their feedback and drive improvements from their feedback. We collaborated with Community Catalyst and a state advocacy group to provide the training to our councils. As part of this training, the members help create rules of engagement for meetings, such as giving attention to the person speaking and limiting sidebar conversations. These rules of engagement were really helpful, and we printed them onto a poster board and displayed them as a reminder at each meeting. In addition, conversations around what contributes to the success of an advisory council, as well as their hopes and fears about participation in that council, were also included in the training. Advisory Council t-shirts were designed and provided to the groups. They're worn to each meeting, and they really help bond everyone as a group. The CareSource employees also wear the t-shirts to help provide a level playing field, and they make the members feel more comfortable, and the members really do love wearing those shirts. Next slide, please. The Consumer Experience Department has strong relationships across the company that we leverage to ensure that we're getting the most valuable insight from members to drive improvements. Meeting topics often include current and future member communication pieces, digital tools such as our website or mobile app, and programs and services we provide, much like Aetna. In order to demonstrate that we're listening and taking action on their feedback, we begin each meeting with an update on what we've done as a result of the feedback received at the previous quarter's meeting. So we find that this is kind of our secret sauce for ensuring that members return to the meetings, and it's a chance to demonstrate that we're listening and that their feedback really does make a difference. We also always reserve time in the agenda to allow for members to bring up their own topics for discussion, and we have care management staff in attendance to help individual members troubleshoot issues that they may be having after the meeting as well. When and if a member brings up a personal health question in the broad group discussion, we let them know that we respect their privacy and that someone is there to listen and assist after the meeting. We want the member to feel heard, but we're cautious not to derail the meeting or violate anyone's privacy, even if they bring up the issue for discussion. And this is always a great time to get those care managers in attendance involved. Next slide, please. To implement a successful advisory council program, it's important to include the appropriate individuals, both externally and internally. From an external perspective, community partners such as the Ombudsman are able to listen to our member feedback, and they can also inform us about issues that may be of relevance to our members. The advisory councils also provide the perfect opportunity for our internal stakeholders to hear member perspectives firsthand. So these stakeholders might be from marketing, digital strategy, transportation, or really any other relevant area. They often attend the meetings in person, and for those who can't attend, we do offer videotapes and written transcripts of all meetings. Full summary reports are written and shared across the enterprise as well, as Chris had mentioned. Across our company, we strive to incorporate the member's perspective in as many of our initiatives as possible, and we find these meetings to be one of the best ways to gain this insight. Care management staff are always on hand at all meetings to address member questions and help them troubleshoot individual issues or barriers if needed to. The Consumer Experience Team has dedicated staff, as Chris had mentioned, for planning and executing the quarterly meetings. As we expanded the use of advisory councils across many of our products and states, we began partnering with a research vendor specialized in focus group facilitation to help us manage the administration of the councils. So this vendor manages the more labor-intensive tasks, such as sending reminder invitations, managing RSVPs, ordering food, and making reminder calls. However, CareSource and the Consumer Experience Team remains really actively engaged, and we often co-moderate along with the vendor at the meetings. Next slide. An example of how we've put our member feedback into action can be seen in our Where to Go for Care magnet. Over several meetings, we noticed a pattern that showed that many members didn't fully understand the range of care options available to them. Therefore, they were often defaulting to the emergency room for many of their care needs. The Consumer Experience and MyCare teams work together to gather council feedback about how members decide where to get care, what barriers they face, and how we could help to better educate them and influence their behavior. Next slide. Members suggested including high-level information regarding the various places they can seek care for their needs, with examples of the types of services offered at these points of care. They also helped us to determine the best names for the points of care. We changed our reference of retail clinic to convenience care clinic, for example, because it was more familiar and intuitive to the members. While this graphic is appropriate to use in a variety of communication channels such as the newsletter or on our website, the members felt that a magnet format would be the most useful and durable way to communicate this information. They also wanted to be able to place it on their refrigerator where they'd easily be able to find it when they needed it. Our care managers currently provide this magnet to members during face-to-face visits, and it's really well liked by the members. The magnets are also now being piloted with some of our Ohio Medicaid members, and the impact's currently being assessed. Each year, we strive to partner with the advisory councils to drive at least one key initiative like this. These are really big wins for our members, and they provide our councils with an example of the impact they're having on their health plan and the lives of our members. We've learned a lot over the last several years about the strategies for implementing successful advisory councils, and we really appreciate the opportunity to share this with you today. Now I'll pass it back to Renee.
Renee, you may be speaking on mute. However, if everyone could enter now, we wanted to just hear a little bit from everyone. From the strategies that we've heard today from Aetna and CareSource. Renee, was that you?
That was me. Yep. Sorry, my mute button was just being very slow. So I'm happy to take it from here if you'd like.
Please, thank you.
Sure, yeah. So thanks. Just thank you to the speakers, Chris and Robin last, but also to Lena and Mark and to Angela and Katherine. You know, at the center, we often say that when it comes to meaningful consumer engagement, the devil's in the details. And so I wanted to thank you all for sharing so many of the specific details on how you've created your consumer advisory committees and how you've continued to support members and maintain those councils. So we're getting ready to start our Q&A time, and I know that some of you have already submitted questions and answers during the speakers' times. But before we turn to those, we wanted to turn back to you all in the audience to take a kind of a quick pulse and ask you to use that Q&A section on the bottom left of your screen, and there's a little picture of it there. Ask you of the strategies that you've heard today from all of the different speakers, what strategies would you like to try at your plan or your practice in order to engage members? You know, are you already using some of these similar strategies before? Or currently, have you used them before? So just send us a brief answer to that question or those questions, again, using the Q&A box at the bottom left of your screen. And I'll call out a few of these. So someone answered that they take the CAPS survey to the advisory committee, or maybe they want to. Somebody noted that they're already using most of these. Similarly, others say that they're using similar strategies. Member focus groups, providing transportation. Let's see what else. Oh, this is a good one, of course. Feed them and they will come, somebody wrote. So that could not be more right. Having food is definitely an incentive for showing up no matter who you are. Let's see. They use, somebody wrote that they like the mass email idea. I think that was raised by CareSource. Someone noted that they're using gift cards. Boy, there's a lot coming in. Thank you all for this. Let's see. Oh, somebody wrote this, and I like this as well. I really like the T-shirt idea and that all the plans shared in regards to personalizing the experience for the members. I think I'll just read a couple more because there are so many. So this one we might be able to handle a little bit later. Somebody wrote, we're having a board member attend the Member Advisory Council, and I was concerned that her presence would inhibit the member participation, that there might be an intimidation factor. That might be something that our speakers can speak to in a minute or two. I'll read one more. Let's see. I really like the idea of conducting outreach to members that are within 10 to 15 minutes of travel time from the meeting facility to ensure in-person attendance. Yes, that was very smart. Boy, there are so many more that I could read. Somebody like the magnet. Boy, sending the agenda ahead of time, those are great practices as well. I could go on, and I thank you all for putting this in. We will put this together in order to help inform our following webinars in this series. So at this time, I want to hand it over back to Alana to take us into the Q&A section. We do have many questions. So Alana?
Great. Thank you so much, Renee, and thank you so much, Lena, Mark, Angela, Katherine, Chris, and Robin for your presentations. Your insight is very valuable. And yes, we've had a number of questions already come in. We now have a few minutes to answer some of those questions. So at this time, if you have any questions, you can submit them using the Q&A feature that you just used for responding to the discussion question as well. So please type it into the Q&A box and press submit. And I'll now start asking some of these wonderful questions that we're getting. Thank you so much, everyone, for your questions. So one of the questions we have, and this can go for either the Aetna folks or CareSource, do either of you place a term limit on how long advisory council members can serve on the committee, and if so, how long?
This is Chris from CareSource. We kind of think about it as being approximately 2 years. If there is if we feel like the group is maybe getting stale, it's possible that we would do it more often than that. And likewise, we may not always keep it at 2 years, but that's kind of a rule of thumb.
And Angela or Katherine, did you use any limits for how long members can serve as well?
So this is Renee. It looks like our Aetna folks got disconnected and they were going to call back in. So let's proceed with some of the other questions for CareSource or for Lena and Mark at the center.
Great. Well, Lena and Mark, I have a question for you. You mentioned how important training is, and you mentioned a couple of examples. Can you talk a little bit about what you've heard has been the most valuable types of training for participants? Anything that you heard from the plans, either through your interviews or your survey?
Yes. So this is Lena. I can take that question, and then Mark, if you have anything else to add as well.
Sure.
I think one of the things, and I can speak to some of the past experiences that we've had working with our advocacy partners on the ground and some health plans. The most helpful type of trainings are ones where consumers are able to get both general education about the program and about what the Consumer Advisory Council means and the purpose of it, as well as some details around what their role will be. I think that they find that when they're serving on an advisory council alongside with plan staff, or if, like someone mentioned earlier, if, board or executive leadership are attending, that there can be sort of this power dynamic in the room. And so, training, and particularly ongoing training, is really useful for members so that they can sort of feel like they're on a even playing field and are able to sort of understand the conversation, follow the conversation, as well as ask questions that are appropriate to the conversation.
Right, and just one more point on that. One of the things we learned was there's a wide range in the types of formal orientations and trainings, and I recall a number of plans talked about having mock advisory council meetings, which simulate for people what might actually occur during a meeting, and this gets to the point that Lena was making, that some people may feel somewhat intimidated, and an earlier finding suggested that a lot of people come, but they really don't speak up. And part of that, I think, is setting the stage, getting people comfortable, and so doing a mock meeting might be one part of a training to get people comfortable to speak up.
Thank you both. So to the Aetna and CareSource folks, are there things that you've done that have helped your participants speak up and maybe feel more like they're on an even playing field and comfortable participating?
I just wanted to confirm you were directing towards CareSource?
Either CareSource or Aetna, either one of you. I'd love to hear from both.
Oh, okay. So what we do to ensure participation is, if we notice that someone is being kind of quiet, we may ask them directly. The group really knows each other. So we try to solicit and draw people out. Just naturally, some people are more introverted than others. And so we try to ask questions and draw them out if we've noticed that somebody is being quiet. And, likewise, if somebody is, kind of seeming to want to talk a whole lot, we will try to say, thank you so much for your feedback. Let's make sure we're hearing from somebody else. So kind of some basic moderation skills.
Hi, this is Katherine with Aetna. To answer that question at our health plan, we really have a lot of member participation. They're very open with sharing things that they have, but our rapport that we have established with them over the years has helped engage them. But we also start off all of our meetings with an icebreaker. So whether it be if it's summer, we'll go around the room and, introduce yourself, where you're from, if you're from a health plan or if you're from whatever city you're from, and then what you like about summer, something to break the ice, and people find that just relaxes them and gets them ready for engagement in the actual meeting itself.
And this is Angela. I just want to add that I think when people join the council, we always emphasize this is about the member. This is about you. And a lot of the changes and a lot of the things that we do, we're not going to be successful unless we have input from our members. So I think when members understand just how important it is for them to kind of share their input, and they see how our advisory council meetings are run, and that it's really the members who are engaging, they become more comfortable with engaging as well.
Great. Thank you all so much. So a little bit kind of going along and facilitation challenges that might come up. Mark and Lita brought up that a challenge is that members may share personal items rather than things that are about the broader membership. And I know, CareSource, you spoke a little bit about this, but sort of when members are bringing up issues that may be more personal or private, what are some of the things that you do, some strategies you use, and maybe any specific language that you might use to really bring the focus back to more global issues? Or that can be for CareSource or Aetna, either one.
Hi, this is Angela from Aetna. I'll just say that normally we'll say, can we table that issue? I'll connect you with a care coordinator, because a lot of times our care coordinators will attend the meeting. And we'll just say, you know what, thank you for sharing that. We want to table that issue, but we do want to make sure that it's taken care of before or addressed before you leave the meeting. So that's kind of the strategy that we use to ensure that personal issues don't overtake the meeting.
This is Chris from CareSource. I'd say we have a very similar approach, same type of, wanting to make sure the person feels heard, that we maintain their privacy, and then try to just let them know that we'll talk with them at the end of the meeting.
Great. Thank you both so much. When you started your council, either one of you, CareSource or Aetna, were you at all fearful that you may get feedback or suggestions that might be hard to address, that the suggestion might be unrealistic, or things that you couldn't do? Do you come across that as a challenge, and is there anything that you may have done to address that concern?
This is Chris. We can speak to that. What we try to do when we set expectations is that's really a natural part of that, where we let them know we're really looking for their feedback regardless of if it's something that we can change immediately. But we also try to set expectations is that things, such as a benefit design or kind of larger issues, that's not something that is likely to be altered within 3 months. So we are not going to be coming back the next time and saying, okay, we've completely revised our benefits. Here's the new information. And so I think it's really about setting expectations, but then continuing, as Robin said, with letting them know how we are implementing the feedback that we are receiving. So it's really trying to hold the balance is that we hear you, and some things we're going to be able to implement, and others might take a while or might not be feasible, kind of depending. But that's something that we don't see as a challenge too often because we set that expectation up front.
This is Katherine with Aetna. We do a similar approach. Additionally, though, even if we can't, when it comes to benefits, if we can't tackle that right away, obviously it takes some time to update those benefits. We do communicate with the members. We recap what was discussed and if there's any new updates about the process of where the suggestions are at within our executive leadership, that is communicated to the council members, just to assure them that we did not forget about their question or their concern, that we're still working on it, and we'll get them the update as soon as we can.
Thank you both so much. So turning a little bit towards recruitment, Lena and Mark, maybe I'll start with you. You mentioned that you showed how plans reported that getting diverse representation on consumer advisory committees is a challenge. Do you have any recommendations or things that came out for suggestions for recruiting people from underrepresented communities?
Hi, yes, so this is Lena, and then Mark, please feel free to chime in. just from our experience working with advocacy partners on the ground, some of the best places to recruit consumers are through community-based organizations, senior housing facilities. Building relationships with the resident service coordinators has been really successful, churches and food banks. And these are just some examples of places where advocates we partner with have engaged with consumers. We've also known that our partners on the ground collaborate with health plans and conduct outreach together, so that when people in the community see a trusted organization with a health plan, they're likely to be more receptive to what the health plan is asking. And we've seen this happen on the ground in states like Ohio and in Rhode Island, where partners that we work with have worked in collaboration with the Medicare-Medicaid plans over there on the ground.
One other point to mention is that when we were looking at our analysis and looking at the types of things that plans were doing to facilitate people participating, we did notice a correlation between the number of what we call accommodations a health plan offers to potential participants and the difficulty they experience with respect to recruiting and retaining. So, for example, plans that are assisting, make the offer of assisting with transportation. They may have food at the meetings, obviously translation services and so on. The more of those basic sort of infrastructure issues that are addressed, the easier it is to attract people and retain them.
Great, thank you, Mark and Lena. So to CareSource and Aetna, are there strategies, either similar ones that Lena mentioned, Mark, that have worked for you for recruiting people from underrepresented communities from your membership?
This is Katherine with Aetna. We do a lot of similar strategies. I mean, we provide transportation. Everybody knows that when they come, they're going to get a well-balanced lunch that has all the nutrients needed and healthy, but also the sense of family. People know who's going to be at the council meetings. They know they're going to see their favorite people. So just even that in itself is something that keeps members coming back.
And this is Chris from CareSource. As Robin discussed, we really take we send invitations to a very broad number of members within the area where we're going to be holding our meetings. And that has worked effectively to help us to get a diverse group of people, of members. And we also offer transportation, that benefit. We have food at the meetings. So those things I think do help provide some incentive. One thing not particularly is relevant to my care, but one thing what we think about in some of our other councils is that we provide child care. So kind of depending on the audience and the advisory council, that can be helpful, knowing that that can be a barrier for some members.
Great, thank you. For both Aetna and CareSource, how do you go about choosing people that might be a good fit for the Consumer Advisory Committee? Can you say a little bit about your application process and what types of information you gather from potential members?
Yeah, this is Katherine from Aetna. We can answer that question. We have our application on our website. Of course, we always carry it around, but we get just basic demographic information. We have a section on the application that says, tell us about yourself, about your background, if they're on any other advisory councils, if they have any experience in that, and then also why they want to be on a committee, what would they offer to the team, and if they're part of any other kind of committees, their race and ethnicity, and if they can attend meetings day or night, evening, weekends, what their availabilities are, if they need transportation and interpretation, and then their membership category, if they're a member or if they're a family member, a community organization, or just an advocate for the member. So we collect that information, and then based on the diversity of the advisory council is who is selected to be on the advisory council. So if we have 100% of African Americans, and we had somebody that was more diverse in representing the population, and another person that had the same qualifications but was from the same, like an African American population. We would likely go with the other diverse person. That way we could add more diversity to the advisory council. So there is a selection process, and that actually does state on our application that we do select it based on gender diversity and the race diversity as well. And it's available on our website that anybody can view as well.
Chris or Robin, anything to add from your experience at CareSource in your application process?
So yes, this is Chris from CareSource, and we really think of it, it's kind of, I guess would look at it from the other way around, is that we start with an invitation to a broad group of members. As we said, Robin mentioned it could be about 3,000 invitations that will get us down to, perhaps 10 regular attendees, ideally 15 who are members of the council, but maybe 10 at each meeting. And so from that, in terms of the types of things we collect from them, so we verify eligibility before each meeting, making sure that the members are, continue to be our members. So that is one check we do. And as far as the collecting of information, we just confirm that we have the accurate contact information because they are our members. This is information that we have about them. And then in terms of the kind of what do you bring to the meeting, that's really something that we talk about when we are starting up new councils, making sure that the members understand what we're looking for and what will be expected in terms of participation. And so we have found this to be a really successful way to find people who self-select as wanting to participate in the program. But, we certainly have people who are more active participants than others, but, that's kind of a natural blending within any group.
Great, thank you so much. Great, well, we're wrapping up on time today. So at this time, if you have any additional questions or comments, please email ric@lewin.com. The slides for today's presentation, a recording, and a transcript will be available on the Resources for Integrated Care website shortly. And we also invite everyone to join us for our next webinar of this Member Engagement and Plan Governance series, Recruiting Members and Supporting Participation in Plan Governance, scheduled for March 5th, 2019. As a reminder, additional guidance about obtaining credits and accessing the links to the post-test can be found within the Continuing Education Credit Guide and the Resource Guide on the left-hand side of your screen, or at the Resources for Integrated Care website. Thank you so much for joining us today. Please complete our brief evaluation of our webinar so that we can continue to deliver high-quality presentations. If you have any questions for us, please email us at ric@lewin.com. Thanks again so much to all of our speakers. Thanks for everyone who participated. Have a wonderful afternoon, and thank you so much for joining us today.
That does conclude our conference for today. Thank you for your participation in using AT&T. You may now disconnect.